Hi, my name is Andrew Weeks. I'm one of the consultants at the Women's Hospital, as well as being a Professor of International Maternal Health at the university. In fact, I spend most of my time over at the university these days. But I've been asked if I'll put together a video on induction of labour and the harms and benefits, because I know that's a thing that has been causing us a lot of concern, and I've been quite vocal about this nationally. So we've always known that there's a balance when you're deciding whether to induce somebody, and there's a balance between things that in favour induction and those against it. Now, traditionally, we said to people, you mustn't be induced. There's all sorts of problems. We'll only induce if there's extreme problems. So, and they'd say, well, what are the problems? We'd say, oh, it increases your risk of caesarean, forceps, postpartum hemorrhage, long labour. We'd say there's potential harms to baby of the induction. There's a cost element to the NHS, and actually it's a rubbish experience as well. So I wouldn't do if I were you, unless there's marked problems. And of course, there were good reasons to induce, because you're halting maternal disease, or you're presenting stillbirth or harm to the fetus, or there's maternal wishes. But those risks had to outweigh all these nasty things about induction. But things have changed a little bit. And if you take the example of postdates pregnancy, which, isn't the most common it doesn't account for most inductions, but it's a good proportion of them. In the drive to reduce stillbirths, which are far too high in this country, people have been studying very carefully then postdates pregnancy to say, well, what's going on here? What is the risk of stillbirth of continuing, and what actually are the risks? We've talked about increased risk to the mother of caesarean section. Do those actually occur? And actually, if you go back to the Cochrane review, then you'll find that actually many of those things are not true. And so, I don't know if people are familiar with these sort of graphs. These are in the Cochrane collaboration, present a lot of their data like that. And you can see these are the risk of caesarean section when you induce labour rather than just leave labour alone. And if you look at the top left-hand corner, this is less than 41 weeks. So this is around term or just before term. And this is the chance of there being a caesarean section. And if you look at all the different studies, all those, whatever it is, 10 studies or whatever, you put them all together, that's a diamond at the bottom, and it shows an overall no effect on the caesarean section, the chance of having a caesarean section. So induction before term or up to 41 weeks doesn't seem to have that effect that we thought was there. But if you go to postdates, so if you take another set of studies which all look at greater than 41 weeks, you see the top left-hand corner again, and there's more studies done in the famous Hannah study, Mary Hannah in Canada in 1992. Actually, you look at the bottom there, actually there's a 10% reduction in caesarean section rates by induction. So it's not that induction carries a risk of caesarean section, actually induction reduces the risk of caesarean section. And what about the other side then? What is the risk of stillbirth that we're inducing for? Well, we know that the risk of stillbirth at each gestation goes up, and people will maybe be familiar with these graphs where you can see it increasing as you go through. These graphs are very difficult to interpret, in fact, because this is the absolute risk at each gestation. But when you get earlier, of course, a lot of the high-risk babies have been induced by this stage. So by the time you get to 41 or 42 weeks, a lot of the high-risk babies have already given birth by then. But you can see how the gradient goes up quite steeply. And if you look at the NICE guidelines, they suggest inducing somewhere between 41 and 42 weeks. And you can see, so you can imagine why, because the risk is going up at that stage. One thing to notice, though, is that the risk, actually on the left-hand side, you can see it's risk per 1,000. So if you look at 42 weeks, that's around 4 per 1,000. So that's about 1 in 250. Now, 1 in 250, is that a high risk or low risk? Well, that's quite difficult to tell, because actually it means that 249 babies aren't going to have a stillbirth at that stage. Only one is. And you're taking an action potentially for all the babies in order to prevent that one stillbirth. Now, looking overall at the risk of stillbirth in the UK, the overall risk is around 230. If you've got a completely healthy baby, of course, it's less than that, but it doesn't really go to zero. We can't predict completely which baby that stillbirth is going to be. They occur unexpectedly still. And then you've got a whole number of factors which increase the risk. So gestation over 41 weeks increases the risk. So does high BMI. Being a smoker or age over greater than 40 maybe doubles that risk. IVF, type 1 diabetes, previous stillbirth raises it even higher, nearly to 3 times. Multiple pregnancy and growth restriction increase it maybe to 5 times. But even at 5 times, that's still taking it only to maybe 1 in 70, 1 in 50, and which some of us would raise our hands up in horror. 1 in 50 risk, what an awful risk. You've got to definitely intervene, but it still means that 49 out of the 50 won't have a stillbirth. How do those risks compare with sort of everyday risks that we take? I don't know if people know, but I'm quite into rallying, motor racing. And I've been around circuits and the Anglesey circuit and such like, and this actually comes from my childhood in Kenya, where rallying used to be a very popular sport. But I do motor racing. Now, nobody tells me, oh, you definitely mustn't, that's far too dangerous, although actually the risk is very akin to many of these risks that we're putting babies through. If you look at skydiving, I would never skydive. Now, my wife has, strangely, and God help me, I'll never do any skydiving. But actually, the risk of that is about 1 in 125,000. So, tiny little risk. Even base jumping, you know, those bonkers people who jump off the top of cliffs wearing wingsuits, still only a risk of 1 in 2,300. That's nothing compared to the risks of stillbirth. Climbing the Matterhorn carries a higher risk, not as high as Mount Everest, but we're starting to get into the sort of range. The closest I can come to actually is having a heart bypass, having a coronary artery bypass graft. About 1 in 250 the risk of death with that, which is the sort of level that you're talking about with risk of stillbirth. Interestingly, that's almost exactly the same as the lifetime risk of a motor accident. So, with motor accidents, most of us travel by car, some of us drive, others of us are passengers, and actually we take that risk. We're not banned from taking that risk. We take that risk because the benefits outweigh the risk of death with it. And it's a little bit the same when we're looking at stillbirth. We need to take in not only the risks, but also the benefits. Now, the benefits from our point of view, we're very used to hospitalisation, we're very used to medicalisation, but many women very much oppose that, and the value of having a natural, spontaneous water birth or whatever is incredibly important to them. And in the same way that I travel by car, despite knowing that there's risks associated with it, so it may be that women choose not to be induced. They may choose not to have a medicalised labour because they value so much a natural birth. So, interestingly, I'm a member of a group called the MatX group on Facebook, and I'm perhaps a little bit of a controversial member because a lot of the people on it are very much in favour of improving maternal experience and a very international childbirth. And I'm sometimes a little bit provocative, and I asked the question at one stage about 6 months ago, at what risk would you advise induction? So for yourself, what risk of stillbirth would it take before you wanted to be induced? Because actually, if we knew for the population that as soon as the risk gets to 1 in 200, you induce, then that would be easy if there was a consensus on it. And I ask you, as you're listening to this, what sort of risk would it be before you advised induction or that you wanted induction for yourself? And interestingly, there were 233 comments, loads of comments all saying, you can't ask that, this is outrageous, this is a nonsense. 70 people actually gave an answer. And where do you think they put it? Let me show you the graph. I guess most of us take about a 1 in 200 professionally, but actually what's interesting here is the widespread. Actually nobody knows, because it's only in retrospect. If you've had a stillbirth, then of course you would have wanted induction at any cost. And if it's been an induction which has gone wrong, then you go, well, duh, what an idiot I was having an induction when actually my baby was fine all along. It probably wouldn't have had a stillbirth. So in fact, you see some people say, well, even if it's a 1 in 2,000 risk, I would want induction. Those are people who are very risk averse from an induction point of view. They don't worry too much about medicalisation. Conversely, there's people right down in 1 in 20 who say, well, I would hate induction. No, it's the worst thing I can imagine. And it's not until the risk came 1 in 20 that I would want induction. Because at that point, well, there's still 19 out of 20 babies who would be fine. Interestingly, that's the same sort of risk of harm that was in the term breech study. So you get quite a lot of people still wanting vaginal breech births, despite the risk of harm being 1 in 20 in the term breech trial. So you can see there's a very wide spread of opinion. And so the question came up then, here's this same graph again, at what stage what is the risk at which you would do an induction post-dates? And so NICE has said between 41 and 42 weeks, and people have said, well, what do you mean? When exactly between 41 and 42 weeks? So there was a huge Swedish study which was run a few years back, and the results have only recently been published, and they've caused a great furore because they took people who were perfectly healthy and had got to 41 weeks, and they randomised people to either induction at that point or to waiting until 42 weeks. Now, it had to, of course, to be a huge study because it's such a small distinction. And as it was in the study in the end, by the time they'd stopped it, they'd randomised about nearly 3,000 women, and 80%, nearly 90% of people in the induction arm had been induced at 41 weeks, and those who waited, well, it was still about 30% of people got induced. A whole number of people just went into labour on their own. And what did they find? Here's the study. It's published in the BMJ if anyone wants to read it. And what did they find? Well, when the study stopped, because it was stopped early because they were worried about the number of stillbirths. And if you look in the induction group, if you look at the stillbirths in those who were induced, there were none. If you look in those expectantly managed where they didn't at 41 weeks, they were waiting to 42 weeks, actually there were 5 stillbirths. And there was 1 early neonatal death, so there were 6 deaths overall. And some people said, well, that's disaster. You can't continue the study. You can't just sit and wait and watch these babies die. And in the end, that's what they decided that they weren't prepared to do. It was no longer ethical to continue the study. Conversely, actually, if you look at that risk, say 6 in 1,300, can you see right in the centre there in the expectant management group? That's about 0.4%, which is what? About 1 in 250. So 1 in 200. Oh, well, that's actually the risk that we'd expect. So inducing stops that risk, and waiting gives you that risk. So this isn't really surprising that people do get stillbirths as they go through. And when you do such a big study, that's of course what you find. But this is the reason why you'll find, it's completely in keeping with this graph, but that's why you'll find that people now are moving towards the 41 weeks for induction, because of that very small risk of stillbirth of waiting till 42 weeks. Only 1 in about 250, only that. And so 249 out of the 250 won't get a stillbirth. But that risk is there, and it's reduced by induction at that point, and indeed it doesn't cause any harm. And if you look at all the other outcomes in that study, there was no difference in terms of postpartum hemorrhage or caesarean section. The question then comes, well, if you're reducing it from 42 weeks to 41 weeks, well, why not go down to 39 weeks, say? What's the problem? Why are you waiting? At every gestation, you're going to get a risk of stillbirth going forward, and indeed that's true. And there's been a very controversial study done. Well, I don't know if it's controversial, but routine induction at 39 weeks was done in the US. It was called the ARRIVE trial. And they took 6,000 women. And this was only just reported now, 2 years ago in the New England Journal of Medicine. And they took 6,000 women, and they were low risk. They were all normal at the point of decision, and either induced at 39 weeks or they were going to wait until 5 days over the due date. Now, in fact, a number of people actually ended up getting induced. So on average, it was 39 plus 3 against 40 plus 0. So actually, there wasn't that big a difference between the two arms. And what did they find? The risk of perinatal death or severe fetal illness, if you were induced, 4.3%. If you waited, 5.4%. So now that's just statistically significant, and so induction at 39 weeks seems to reduce the risks compared to waiting from the baby's point of view. And you might say, well, yeah, no, we know that, but it's rubbish for the woman, actually. It'll increase the caesarean section rate. Did it? Oh my goodness. Actually, it reduced the caesarean section rate, strangely. The induction of the caesarean section rate in those induced was 18% compared to 22%. Of course, these are a mixture of emergency, mainly emergency caesarean sections, but some elective in those who waited. And so caesarean section rate inducing actually reduces the caesarean section rate rather than increasing it. And what about, well, the women must have hated it. Well, actually, it led to less pain, and the women themselves perceived that they had more control in labour because they knew exactly when they were coming in. So this has caused a huge amount of discussion and thrown this traditional model out of the window. So although traditionally we said it caused all sorts of harm, well, actually in 2020 it doesn't seem to harm the mother, doesn't seem to harm the baby. There's been cost analysis as well, and doesn't seem to increase the cost, because the main cost actually isn't the induction, it's emergency caesarean sections. And what you're left with is saying, well, it's not a very nice experience. It does seem to improve outcomes both for the mother and the baby, but it's not a very nice experience. The one thing I'd say that we need to go a little bit careful about was that the previous studies which I'm talking about were done under clinical trial conditions, which tend to be more perfect than average. We tend to look after these patients a little bit more carefully. And so, in fact, if you go to real life, you may find with real life things aren't quite as rosy as they are in clinical trial conditions. You may find that on some days there's overcrowding and women are waiting and there's long delays. There's lack of one-to-one care because people are being taken through to doing the inductions. And of course, if you have all these things, then you may find some of these coming back. So it's a little bit of a caveat. Just be careful. But it certainly doesn't look as if induction does any harm. But what about maternal experience? There's been some studies done of induction, and actually what women seem to value, they value ownership, they value social needs, being able to organise their social needs around the timetable, rather than just being told, you're coming to that day, you're being delivered that day. That's about ownership. The decision process was important to them, and they need to understand why they're being induced, if they are induced, or they need to be part of that decision. And that we can do all that. There was a 35-39 trial where they induced women who got to 35 years old at 39 weeks, and those women had far more induction, and indeed there was no difference in maternal experience, which was looked at really quite carefully in that study. But there are tales around, and anecdotally, a number of the consumer groups are concerned that what happens in clinical trials isn't always happening out there, and so there's reports of coercion. So you must be induced. It's routine here, and actually women don't necessarily want to do that, or they say, well, I don't want to be induced. And do you want your baby to die? Now, if you're talking about a risk, even of 1 in 100, it's not that your baby will die if you're not induced. It's a 1 in 100 chance that your baby will die if you're not induced. 99% of the babies won't be. So we need to be very careful with our wordings and not unnecessarily scare women. I caused some controversy recently by writing an article in the British Journal which we argued that induction of labour was an appropriate method of managing labour, and indeed it's interesting because they put the title, "It should be offered to all women at term," and what actually we said was induction at term may not be for everybody, but it's a sensible and valid birth choice for all. In light of the evidence, it's certainly unethical to refuse a request for term induction. And in the era of Montgomery, this is, remember, the legal case, could even raise legal concerns. So we're not saying it has to be done for everybody, but we're saying it's not an unreasonable choice and we shouldn't really be refusing people. Now, of course, induction at 31 weeks, you can go anywhere from it being completely routine care, oh, you have to be induced, or a routine offer, would you like induction, to, well, if women ask, yeah, that's fine, yeah, induction is fine. Or what used to be the case up until 3 or 4 years ago is we'll only induce in exceptional circumstances, or you say, well, no, it's not allowed at all. No, that's inappropriate. So we've sort of moved a little bit. So the guidelines up until recently has said only in exceptional circumstances can you do it for maternal request in a healthy baby. But actually that, as I've shown, doesn't really fit with the evidence. Are we at a stage at which we could agree if requested? I think that's where we are at the moment, that actually if women say, I'd like to be induced at 39 weeks, actually we try and fit them in, and we're in fact organising our services around that. Should it be a routine offer? Well, that's a little bit different, and I think that we're steering away from that at the moment. We're holding back from meeting everyone at 39 weeks and saying, would you like to be induced because it reduces the risk of stillbirth? Partly because that's a little bit of scaremongering, and as soon as people hear the word stillbirth, they'll immediately shudder and think, oh, I must do. And partly because of this issue that we can't necessarily provide clinical trial conditions. So we're steering back a little bit from that, and I think where we are at the moment is that we don't refuse it. If it's ever requested, or if anyone wants to discuss it, we give people information about it. So, to conclude, how do we make the decision for induction? What would I personally recommend? Well, I think firstly, we need to have clear local guidance, and that's important from a legal perspective, that we take safety absolutely seriously. But I don't think we should be forcing women to take that guidance. It's only guidance. And we're saying the risk maybe of stillbirth in a particular situation is 1 in 200, 1 in 100 maybe, 1 in 500, whatever. What do you want to do with that information? And then it's the woman's choice. And I don't think we should be badgering women saying, oh, you have to because that's routine policy, you have to do this, or that it's dangerous if you don't induce, because it's not actually. And I think we need to take far more consideration of what the woman wants in this situation. Secondly, I think we need to adapt the protocol, any induction protocol, to our own priorities. Now, that's not always easy in a very busy service, but I think we need to be careful that we can adjust things, we can tweak things. And if a woman says, well, actually, I don't want to be induced at 41 weeks, I want to wait until 42 plus 2, actually, that's okay. If she knows there's a risk associated with it and we can try and quantify it, it's always very difficult to put exact figures, but there's no reason why she can't take that, because it's not. The likelihood is that it'll be absolutely fine. And of course, this is where we run into problems sometimes, because we get a bad reputation because we say you need to be induced, and a woman decides to go her own way, the brave woman fighting against the system, and the baby was fine. Well, it's highly likely that it would be. The risk was only 1 in 100, so 99 out of 100 babies would be fine. But it makes us look a little bit stupid because we've tried to force her to do something that she didn't want to do, because we told her there was very high risk, and actually it's not very high risk. So I think we need to be flexible. We need to adapt the protocol to her own priorities. I think we need to warn women that induction can be difficult, but I don't think, based on the evidence, we can refuse induction for any woman once she gets to 39 weeks. Before that, there is some problem with induction because of respiratory problems for the neonate. So going before that is more difficult, and we can have a whole nother talk about that. But by the time you get to 39 weeks, there doesn't seem to be any excess risk from the baby's point of view. I think we need to be careful about what we talk about with data. We need to ensure that there's accurate data, and that's sometimes very difficult, or to be honest, that we don't know the exact figures, but we need to present it appropriately. And the trouble is that as soon as you say the word stillbirth, then there's a risk of stillbirth. People don't hear that it's a 1 in 500 risk of stillbirth, or that it's a 1 in 300 risk of stillbirth, or you talk of an increased risk of stillbirth. People switch off to everything else. It's suddenly, I'm going to kill my baby. So we need to go very careful, and sometimes there's far better ways of presenting the data now. Do you talk, for instance, of a stillbirth rate of 1 in 230, or do you say actually the chance of a good outcome is 229 out of 230? Well, those are two very different things, aren't they? And the same as if you describe it in percentage term, you might say, well, the risk of stillbirth is increased from 0% to 0.4%. Or do you say that actually the risk of a live baby is reduced from 100% to 99.6%? We can use both of these, and I think sometimes it's worthwhile telling women exactly that. But I think we need to go careful with the use of words. High risk of stillbirth is a very toxic term, and it's actually not true. I don't get into a car saying, well, I shouldn't be driving because my lifetime risk of driving is very high risk of death. It's not very high risk of death. The vast majority of people don't die in car accidents. It's only 1 in 250. So I think we need to be careful about using this coercive language. And I would suggest, we couldn't discuss it, but I would suggest wording something like, stillbirth is thankfully very rare, but actually we can reduce that by induction. And that gets over to women that actually it's not a high risk, but actually we're still reducing it. Thank you very much.